Good afternoon, everyone. Thank you for joining our first, probably likely mini town halls as it's relating to the COVID-19 vaccinations. It's been a really challenging and difficult year, I think, for all of us. We have definitely gone through quite a bit as individuals, as a community, and as a network. But now with the hopefully quick approvals of the COVID-19 vaccines, I think this will probably be a turn within the pandemic itself. And so it appears that there is light at the end of the tunnel. There is a ray of hope and optimism that I think will be coming in the next couple of weeks. Our goal for today's town hall is really to be transparent and to disseminate as much information as we know now, so all of you can be informed in thinking about the COVID-19 vaccination, but also to let you know how we're approaching it here, both at ZSFG, but across the entire San Francisco Health Network. Just to give you a brief overview of our agenda for today, first, we're going to have a welcome by Dr. Hallie Hammer, who is the Director of Ambulatory Care for San Francisco Health Network. Then Lisa Winston and Vivek Jain will give us some updates on the vaccines, some of the data and safety about it, and answer, I think, some of your questions that you sent in advance. We'll hear from Tiffany Rivera from the C3, who is part of the Incident Command downtown, to talk about how the state is thinking about distributing vaccines. And then lastly, Ellen Chen and myself will talk about how we're going to approach staff vaccinations beginning likely next week. Throughout the presentation, we ask that you enter questions in through the Q&A on your right-hand side. As you type them in, we'll be keeping track of them, and then we'll be answering them at the end of the webinar. So why don't we go ahead and begin? I'm going to welcome Dr. Hallie Hammer to start us off with a welcome.
Hello, everybody. And thank you for the opportunity to be with you today to talk about this really important development in our work in the Department of Public Health to fight this terrible pandemic. We started out the day today hearing from Director of the Department of Public Health, Grant Colfax, that deaths in the United States now have from COVID have exceeded the number of people we lost in World War II. So we just sat with that number, and I have to say that sense of dread and horror that we all are experiencing as we're in our 10th, 11th month of working against this terrible pandemic. Especially in San Francisco, as we ride this current surge, our most serious surge, and try to reverse it, I have to admit that is tempered for me by the sense of excitement, the butterflies in my stomach that I feel, that I associate with my birthday approaching, or holiday, or falling in love, because I have a sense that there's something really good around the corner, and I'm so excited that we have this vaccine, we need to be able to protect our most vulnerable people first and foremost, including our frontline healthcare workers from this terrible illness, and the vaccine is definitely our best option for doing that. We in San Francisco have been successful in flattening two curves in fighting against two past surges. We're going to do it this time with our stay-at-home orders. We're already seeing some promising signs, but really the vaccine is our ticket to protecting everybody from the illness. So I don't want to go on too long, but I just want to really, really thank Luc John Day, Lisa Winston, Rosalie Ferrer, Jessica Chung, and so many others at ZSFG, along with Ellen Chen and Josh Nossiter, the ambulatory care leaders who have been working tirelessly since we got news of the vaccine coming to put this plan in place. It's a huge operational lift, and I just can't thank them enough. So with that, I'm gonna end and look forward to this discussion today.
Thank you so much, Hallie. Really appreciate that. So why don't we go ahead and begin? We're going to start, and a large part of the presentation is going to focus on what we know about the COVID-19 vaccines. And so Dr. Vivek Jain is going to start us off in talking about some of the vaccines.
Thank you, Luke, and welcome to everybody who is dialed into the call. I'm Vivek Jain. I'm an infectious disease specialist at San Francisco General Hospital. I'm the co-director of the infection control team and the director of the ID clinic. I'd like to thank all my colleagues for everything everyone's doing on the COVID response, and I share the real optimism that Dr. Hammer laid out. So I'd like to just give a short presentation on the Pfizer, BioNTech, and Moderna mRNA vaccines. I think everybody has been following the news, and I'd like to delve into some of the details. The idea of using nucleic acids like DNA and RNA as a way of vaccinating has been around for a long time, but there have been some real molecular biology and biotech innovations that have enabled these vaccines to come forth and be successful. So first of all, the mRNA in this, at the center of the vaccine, codes for the SARS-CoV-2 spike protein. SARS-CoV-2 is the virus that causes the disease COVID-19. This RNA codes for a full-length spike protein of the virus, and one of the innovations is they realized that doing just the receptor binding domain at the edge was causing excess reactogenicity. So the technology now codes for the full-length spike protein. And further, they've made modifications so that the protein is stabilized in what's called a pre-fusion conformation. That's a three-dimensional shape that helps optimize how it primes the immune system to create good responses. Second, they've had to do some real engineering on the RNA molecule at the center of the vaccine itself, and that is because our immune system in general is hardwired to recognize foreign nucleic acids like DNA and RNA from viruses, bacteria, and other pathogens. We're hardwired to recognize those, generate an immune response, and destroy those. So to prevent that from happening and let the RNA do its job, they have modified the uracil that is part of the RNA so that the RNA is a modified form, and this type of RNA reduces the inflammation caused. It stabilizes the RNA, and it boosts the level to which this RNA can be translated into actual spike protein for priming the immune system. Next slide. The other technological innovation here is that the RNA is embedded in what's called the lipid nanoparticle. And what this is an engineered sphere made up of lipids and cholesterol that encapsulates and surrounds the RNA and allows it to be injected. So the delivery of the vaccine is this lipid nanoparticle injected into muscle. And what you can see in the figure in the lower right-hand part of the screen is that the particle is taken up into muscle cells, broken down, the RNA is released, and then translated into actual spike protein, which is then presented to the immune system to prime a response. Next slide. So I'd like to now share with you results of the major clinical trial that has brought forth this vaccine. I think people have seen a lot of this in press releases and in the media. Yesterday, the formal publication was released in the New England Journal. I'd like to just share those results with you now. So this is a phase 2, phase 3 study of BNT162b2, that is the name of the vaccine, versus placebo. The regimen is a series of 2 shots spaced 21 days apart. This trial began enrolling in late July and was conducted in 6 countries as well as locations in 39 United States. It enrolled adults 18 to 55 years old, as well as adults over 55 years, and then expanded to include 16 and 17 years old. So it also enrolled healthy individuals as well as individuals with stable comorbidities, and these included persons with HIV, hepatitis B, and hepatitis C. It also included persons with or without a positive COVID serology at baseline, but importantly, it excluded persons with a known medical history of COVID-19, immunosuppressing conditions, or anyone taking immunosuppressive medications. It also excluded individuals who are pregnant or lactating. And the data that the company has presented to the FDA are for the full group, so this is individuals age 16 and up. What you can see on the right side here is that there was a relative good balance of male and female individuals in the trial, roughly 50-50. 83% of the trial participants were white, about 9% Black or African American, and 28% Latinx individuals. 58% of the group was in the age 16 to 55 category, while 42% were over 55 years old. Next slide. And these are the results that have generated so much excitement and optimism for what lies ahead. So the primary outcome of the trial is the vaccine efficacy against COVID-19 measured starting at least 7 days after the second dose. And a total of 170 cases of COVID-19 were diagnosed. And what you can see in the red boxes is that only 8 of those 170 cases occurred in the vaccine group, while 162 of those cases occurred in the placebo group, and that computes to a vaccine efficacy of 95%. In blue down below is a bigger group of people that included individuals who did have evidence of prior infection. Their serology was positive at baseline, and the results are much the same. A real skewing of the COVID cases to the placebo arm, again for a computed vaccine efficacy of 95%. Very importantly, this very high vaccine efficacy was high, and it was similar among individuals over the age of 65, who we know are our highest risk for morbidity and mortality. It was also similarly high in males versus females across all age groups, across all races and ethnicities. And it was also similarly high among patients with obesity, hypertension, and the other comorbidities that we know raise the risks of COVID disease. Next slide. Now, in terms of the vaccine, there were some side effects that I would like to take you through. The first is just a simple, what's called an injection site reaction. These were quite common in trial participants. The most common injection site reaction was mild to moderate pain at the site of injection. These were mostly resolved in 1 to 2 days. But these occurred in 83% after the first dose and 71% after the second dose in the younger age group people, and 78 and 66% of people among the persons over the age of 55. Redness and swelling was much less common, while pain was actually the most common reaction. Away from site reactions and looking at systemic reactions, there were a variety of symptoms that occurred that included fatigue at 63%, headache 55%, muscle pain at 38%, and chills, joint pain, and in a smaller group, fever. Like above, most of these resolved on their own in 1 to 2 days and were not very consequential. Interestingly, all of these reactions were more common after the second dose than they were after the first dose, and the reactions were more common in the younger age bracket compared to the older age bracket. Next slide. I've included this in the deck just so you can see if anyone's interested in much more detailed information about specific side effects occurring in the vaccine and placebo groups after dose 1 or dose 2 in the younger age group versus the older age group. Next slide. And this is the timeline that we've been looking at for the Pfizer-BioNTech vaccine. On November 20th, they submitted documents seeking an emergency use authorization from the FDA. On December 2nd, as people may have seen in the media, this vaccine was formally approved in the United Kingdom. And on December 10th, yesterday, the company presented data to an FDA advisory committee, which then voted in favor of recommending the granting of the EUA. So the decision on the EUA is now with the FDA and is expected shortly. Next slide. Switching over to the other lead vaccine candidate, the Moderna mRNA vaccine, I'd like to share some results from the phase 3 trial of that vaccine. Also began in late July of this summer. 30,000 individuals have been enrolled. It is also a 2-shot series with the dosing spaced 4 weeks apart instead of 3. This trial has enrolled 3 groups, persons over the age of 65, persons under 65 who are at increased risk of COVID complications, and persons under 65 who are not at risk. They took all comers, meaning baseline serology positive was allowed, and they have fully enrolled by the end of October. They're going to be following patients for 2 years. What you can see in the pie chart here is that they have done a decent job of enrolling individuals from diverse backgrounds, 20% of the trial, Latinx individuals, 10%, Black or African American individuals. And the bar graph in the lower right of the slide shows enrollments from different age groups. Importantly, in green, 25% of the trial is over the age of 65. Next slide. Here is also some information from the Moderna study showing in the upper left that they have enrolled 58% of the trial 18 to 65 years old and not at risk. In purple, persons over 65, and in yellow, persons 18 to 65 who are at risk. So a spread there. In the upper right, you can see comorbidities of patients who are enrolled, and they have enrolled quite a number of people with medical comorbidities, a pretty even gender distribution, and so the trial is reasonably diverse. Next slide. These are the efficacy results of the Moderna vaccine. Now, importantly, this is what we know from a press release. We do not have published information yet. And what has occurred in this trial is that there were 95 cases of COVID-19 diagnosed using an endpoint that starts 2 weeks after the second dose. And out of those 95 cases, 90 occurred in the placebo arm, while only 5 occurred in the vaccine arm, for a computed vaccine efficacy of 94.5%. So almost identical to what we saw in the Pfizer-BioNTech vaccine trial. Also importantly, severe COVID-19 cases, there were 11 of those, and all 11 of those occurred in the placebo arm. None occurred in the vaccine arm. What we know so far about adverse effects here is that the majority of events have been mild and moderate and short-lived. We don't have detailed information yet on the grade 1 and grade 2 events like what I showed earlier. And grade 3 events have been quite rare. Like the Pfizer vaccine, there are more side effects following the second dose compared to following the first dose. The timeline for the Moderna vaccine is as follows. They have submitted an application for EUA approval on November 30th, and they will be presenting to the same FDA advisory committee next week, December 17th. Next slide. Lastly, just one very common question is how durable is the immune response to these vaccines? And what I'll say is largely we do not yet know. The participants are going to be followed for quite some time, and we will gain this information over time. So data are still emerging on this question. One recent report I would point you to is on the Moderna vaccine, where they looked at immunogenicity data out to almost 4 months after the vaccination in a small group of individuals. And what you can see in the top row in the upper right is antibody titers rising after vaccination. These are binding antibody responses. They rise to good levels. You can see that they decline a touch over time. And in the rows 2, 3, and 4 are other graphs showing neutralizing antibody titers also rising to pretty high levels, and then showing some signs of small decline over time. Importantly, though, these levels of antibody are higher than what we would typically see in persons who've had COVID and recovered from it. And the correlates of immune protection are not yet very well understood as an active area of research, so we're going to have to see how this plays out over time. Next slide. And lastly, just a quick word on the logistics on vaccine distribution. I think people are aware that the Pfizer-BioNTech vaccine has to be shipped in dry ice transport boxes in ultra-cooled temperature down to -70 Celsius. Once it's taken out of the box and put into a standard -70 or -80 freezer, it has to be used in 6 months. The transport box can have its dry ice swapped and every 5 days, and that can be used for 15 days. And then once put into a standard refrigerator at 2 to 8 degrees C, you must use within 5 days, and its stability at room temperature is limited. It's got to be used by 6 hours. In contrast, the Moderna vaccine does have improved logistics, primarily because it does not require the ultra-cool freezer cold chain. It is shipped and can be stored in standard freezers, which are at -20 Celsius. Once put in a refrigerator, standard refrigerator, can be used for 30 full days, and at room temperature stable for 12 hours. So there are a number of favorable logistic features there. Next slide. So thank you for the time in summarizing, and I'd like to turn it over to my colleague, Dr. Winston.
Okay. Thank you, Vivek.
Hello, everyone. Thank you. We're going to go through, we anticipated some questions that you might have because we have some of them ourselves. And then a couple of people did send in some questions ahead of time. We're going to try to answer those. I'm going to be fairly brief because we're going to have a Q&A session at the end. Next slide. Okay, so common questions, and Vivek went over this a bit already. How long will immunity last? We don't know. So are we going to need more shots to boost our immunity? We may well. We don't know the answer to that. I think not only is it going to depend on how long the vaccines protect us, it's also going to depend on what happens with the virus and how widely it's circulating. So those will be things that we have to determine later. In terms of protection after just the first dose of the vaccine, would you mind showing the next slide? So the study of the Pfizer-BioNTech vaccine was not designed to test single dose. But what they showed was after about 14 days before the second dose had been given, the lines in this graph were already starting to diverge, showing that people were getting some protection from the vaccine dose. The vast majority of the people in the trials got 2 doses, but in the people who, for whatever reason, got 1 dose, they did seem to have some effectiveness from the vaccine. So we hope to learn more about this. We hope we'll be getting everyone 2 doses of the vaccine in a timely manner, but it is intriguing and does suggest that there may be some effectiveness from a single dose, which is very similar to what we see from other vaccines that require a booster dose. Next slide, please. Okay, so some other common questions. Is the vaccine recommended if one already had documented COVID-19 infection? So the answer to this is yes. It is recommended regardless of whether you know you have antibodies and know you have COVID-19. One of the things that we're going to be looking for in terms of public health guidance, it's possible that people who have had COVID-19 within the last 90 days may be asked to wait a little while to get their vaccines, because it does look like people who very recently had COVID-19 do seem to have protection. So we're not worried about safety of the vaccine in people who've had COVID-19, but it might make sense for people who very recently had the disease to wait a little bit before they get their vaccine. But again, we expect that everyone will be vaccinated. Another common question. We are so ready to stop social distancing and wearing masks. Oh my goodness, I am sure that everybody is just as ready as I am. But no, getting your first or your second dose of the vaccine will not mean that we're going to stop wearing masks and having social distancing recommendations. The reasons are, number one, we know that the vaccine is not 100% effective. And COVID is still really common. It's just going to take a while before we get enough people vaccinated that we're going to change the trajectory. The other thing that's really important is that the primary endpoint of the vaccine trials is to look to see if people get symptomatic disease. So people who develop symptoms were tested for COVID, but they actually have not reported data yet on testing people who were asymptomatic to look to see if people were getting infections despite not having symptoms. And we do know that people who are asymptomatic can transmit disease. So we still need to learn more to find out. We know that the vaccines protect the person who is vaccinated against getting sick, but we don't know yet whether they prevent you from transmitting virus to others. Next slide, please. So I think I answered the question on the left. And if the vaccine fails and you get symptomatic COVID-19, does it prevent transmission? Gosh, we hope so, but we don't know. We don't know about the prevention of transmission. We are hoping to learn good things in the future. Next slide, please. Okay, so I think this is the most common question that I have been getting. And women who can people who are pregnant or breastfeeding receive the vaccine? So very unfortunately, pregnant people and those who are breastfeeding were excluded from the initial parts of the phase 3 trial. So we just don't have any data as yet. But people who are running these trials are really working to answer this question to enroll people now. So we are hoping that we are going to have more information relatively soon, at least for small numbers of particularly pregnant people who have been vaccinated. And we probably don't have to wait too long because most side effects of vaccines happen relatively soon after vaccination. So I don't think we're going to have to wait, a year or two to make sure that it is safe in pregnancy. We're going to be following very closely. We are hoping that the CDC and the Advisory Committee on Immunization Practices are going to put out some guidance on these very important questions. We'll be looking to those closely. And then depending what guidance we're getting, we'll be passing that along, but it may change relatively quickly. We do know that for those in the 16 and 17 age range, that they'll be included in the initial vaccine groups, assuming that the FDA does give emergency use authorization, or EUA, which we're expecting. The study, the Pfizer-BioNTech study, is now including children down to the age of 12. So we will have more data. We are not going to have data for a while in children under the age of 12. We're gonna have to try to answer that question going forward. Next slide, please. Okay, concern about long-term effects. None known from this technology. It's new, but both studies that Dr. Jane mentioned are following participants up for 2 years, as are all the other large studies. You may have heard in the United Kingdom that there were 2 reports that have been reported in the press on allergic reactions that were described as anaphylaxis. We will be hopefully getting more information and recommendations on that. There may be some precautions for people who have a history of severe allergic reactions, but we may be able to still vaccinate people with an observation period. So stay tuned. We hope to learn more about this topic, but in the trial in the US, allergic reactions were very uncommon. So should you get one of these vaccines or wait for another vaccine? And there may be other vaccines coming, but the data from these 2 initial vaccines are very promising. And I think it's going to be a while before we get comparable data and emergency use authorization of the other vaccines. So our personal recommendation is to access one of the current vaccines as soon as it can be offered widely. And then the last question I think on the slides is, does one need a serology test after taking the vaccine or to check your antibodies to ensure that it has worked? And the answer to that is no, it won't be done routinely. And it did seem to work, at least for the time period that was studied. And we will learn more going forward, for example, if it's helpful to get antibody tests, in the months after getting the vaccine to see if you need a booster. But for now, there won't be any antibody or serology testing after the vaccine. Luke, can you remind me? I think that is the last of the common question slide.
It is. Yeah, that is correct.
Okay, perfect. So I'm going to just take this opportunity to answer a couple of other questions that came in. So one, this is relatively specific, but I think it's actually pretty common. So this is about if you got a shingles vaccine and you're going to be due for your second vaccine, maybe before you're going to be able to get your COVID shot. So I'm going to generalize just a little bit and say that people who were in the study did receive flu vaccines, but actually they didn't receive other vaccines during the time period that was studied. And so I think in general, out of caution, the guidance we're likely to get is, if you can, to try to avoid receiving vaccines around the time you're getting your COVID vaccine. But the particular guidance for this individual who's due for their second vaccine is that for your shingles shot, and actually for most other shots that require multiple doses like hepatitis and those sorts of things, the recommended period in between the first and the second doses, that's the minimum recommended period. But it's really okay if you push it out further and don't get your second vaccine until later. The vaccines still work when you do it that way. So it may mean a delay in getting the second vaccine, but that shouldn't cause problems, and it does not mean that you have to start your series over. Another question. If you have side effects after getting the vaccine, does that mean that the virus is replicating and I could possibly infect my partner? And the vaccines only have, they make you make a protein, but you're not actually infected with the virus. So there is no way you can get COVID from receiving the vaccine, and you can't transmit it or cause side effects in someone else because you received the vaccine. There's a specific question about which vaccine we'll be getting. And I think that might have been pretty clear, but just in case, the initial vaccine that we're getting is the Pfizer-BioNTech vaccine, and we think we'll be getting that next week, as Luke will be describing. But it is possible that we could also get the Moderna vaccine in the not too distant future. But it's Pfizer to start with. And I think the other questions have all been addressed. So Luke, thanks a lot, and I will stop there.
Great. Thank you so much, Lisa. And I'm sure there'll be many more questions at the end of the town hall. So thank you both to Lisa and Vivek for giving us that comprehensive and outstanding overview of the vaccines. We're now going to transition to talking about how the state and then ultimately San Francisco has been thinking about vaccine distribution. So I'm going to hand it over to Tiffany Rivera.
Thank you, John. So good afternoon, everyone. My name is Tiffany Rivera. I'm the Deputy Director for Department of Public Health, San Francisco Department of Public Health's Emergency Preparedness and Response Branch. For this activation, I am the healthcare systems lead for the vaccination team, and I'm going to be discussing a little bit about the state and local plans regarding prioritization and allocation of the vaccines. I am at the COVID Command Center, which is why I have my mask on, so hopefully everyone can hear me okay. Next slide, please. So what we have here is a graph that shows the phased vaccination approach in regards to dose availability. So as you can see on the left column under phase 1, this is where we are ramping up production of the vaccine. This is the stage that we are in now. This should be a short period of time, but we don't actually know how long this time will be. So while we are ramping up, we will be in phase 1 and into phase 1A and 1B. So if you look at the box that's in the green, you will see what phase 1A is. And these are, I'll get into a little bit more about how these phases were defined, who recommended these definitions. So 1A should be paid and unpaid persons serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials and are unable to work from home. And phase 1B would be other essential workers, people at higher risk of severe COVID-19 illness, including those older than 65. So then as we have more production of vaccines, we'll go into phase 2, which is the column in the middle. And this will consist of the people that we will vaccinate during this phase 2 will be the remainder of phase 1A. people who are considered critical populations, so people with comorbidities, and then the general population. And then phase 3 is we have regular production of the vaccine. We will have discontinued vaccination and routine vaccinations, and that will again just be a remainder of anybody else from the previous phases, and the general population with the critical populations emphasized. Next slide, please. So what do we know so far? So logistically, we don't know a whole lot, but we learn a little bit more every day. Information is changing very rapidly. It's changing daily. So please bear with us with this information. It does change quite often. So as was mentioned, we have 2 vaccines that are coming down the chute. The first one being the Pfizer vaccination, which, as has been mentioned, is pending EUA. And this we're hoping happens in the next day or so. As soon as that happens, the federal government is shipping these out and expect local jurisdictions to start vaccinating as quickly as possible. So the federal government has allotted the state of California 335 boxes of this Pfizer vaccine. Each box has 975, I believe, or 957 vaccinations doses in each box. So this will be about 327,000 doses for the state of California initially. This is just the initial allocation. Of that initial allocation, the county of San Francisco will be receiving 13 boxes, which would equal about a little bit more than 12,000 doses, a little under 13,000 doses. They are to arrive the week of December 1st. We don't have an exact date, but we expect it to be around the 14th. And then we are expecting another allocation of Pfizer vaccine to come the following week. And we don't quite have those numbers. It's about a week or 2 after the initial. We don't have those numbers yet, but we are being told it will be a lot more than what we're receiving initially. These will be distributed to the hospitals, but they cannot be administered until recommendations from the Advisory Committee on Immunization Practices it gives us the go-ahead. We also here in the state of California have the Scientific Safety Review Work Group, which has turned into a Western regional work group. And so they will be reviewing all the information on these vaccines and providing recommendations to the state. Once all that is done, and we have approval from the state, then we can go ahead and start vaccinations. And we expect this to happen very rapidly over the next couple of days because we are expecting to receive it at the beginning of next week. As was mentioned, we will also be receiving Moderna. We have less information on Moderna, but we do know that it's right on the heels of Pfizer. They are also pending EUA, should happen very shortly after Pfizer, and we have been told that SFDPH will be getting an initial allocation of 6,000 of these doses the week of December 23rd, with more doses coming a couple of weeks later, about 2 weeks later. So the state will be allocating this initial doses to the multi-county entities. This might be a little confusing. Multi-county entities are hospital systems that span multiple counties. So UC Health Systems, Dignity, Sutter, Kaiser. Those vaccinations of the Moderna vaccinations will come straight to the state to those facilities. So these 6,000 doses that they are providing to the county of San Francisco will be dispersed between the remaining hospitals within the city and most likely to some of the skilled nursing facilities. Next slide, please. So we'll get into this in a little bit more detail in just a couple of slides, but the ACIP and the CDPH Community Vaccine Advisory Committee provided some recommendations for prioritization during phase 1A. Again, these are just recommendations, and we have not been given official guidance from either the state or federal government around this. But they do suggest that in phase 1A, we should be vaccinating healthcare workers with high-risk exposures and skilled nursing facilities, both their staff and their patients. A quick note on skilled nursing facilities, the federal government has teamed up with CVS and Walgreens to vaccinate all skilled nursing facilities and long-term care facilities. We do not know when this program will start, but we hear that they most likely will begin the week of Christmas. And so until they start, San Francisco Department of Public Health will be working to allocate the county dose of vaccinations to some of these nursing facilities to get started vaccinating their healthcare workers. Next slide, please. So what does the county do? So our job is to allocate the initial doses as equitably as possible to all the hospitals. So we do this by taking into consideration the percentage of the healthcare workers of the entire county that belong to that hospital, the number of COVID-19 cases that are currently at these facilities, readiness to receive the vaccine. So all the things that were discussed regarding the cold chain storage and the ability to start vaccinating staff, having plans in place to do that, taking all of that into consideration when deciding on the allocations. After this initial allocation, further allocations will be taken care of in a mixture of different ways. So the state, like I said earlier, will be taking care of the multi-county entities, serve Health, Sutter, Dignity, and then the county will coordinate with the other facilities that are left in the city. Next slide. So the guiding principles of staff vaccinations, our goal in this is to curtail the transmission of SARS-CoV-2, reduce the severe morbidity and mortality, and minimize the negative societal impact. The allocation criteria, we define this criteria by using risk-based groups that are prioritized by risk of members. So those that are at high risk of severe sickness and death, those at high risk of spreading the disease, and those at high risk of acquiring the infection. Next slide, please. So what we consider to be the most thing in developing these allocations is equity and ethics. So the goals are the benefit and the greatest amount of people while limiting harm. We prioritizing equity, being as transparent as possible, and using scientific evidence to make these decisions. Next slide, please. So based on these concepts of equity and curtailing transmission of the COVID-19 vaccinations should be offered to the following individuals. So persons at risk of exposure to SARS-CoV-2 through their work and role in any role in direct healthcare or long-term settings. Persons at direct risk of exposure in their non-clinical roles, such as environmental services and patient transportation or interpretation. Next slide. So this is the slide that kind of breaks down into tiers what phase 1A will look like. These again is based off of recommendations from CDPH's Community Vaccine Advisory Committee. So they are not official guidelines that have been given us to us by the state, they're just recommendations. This makes it more of like a foundation, and it is not comprehensive or complete. So there will be other staff within these tiers. So tier 1A, the people that will be vaccinated immediately will be acute care, psychiatric and correctional facility hospitals, skilled nursing facilities, responders, specifically paramedics and EMTs, dialysis centers. Tier 2 of phase 1A will be intermediate care facilities, home health and in-home support services, community health workers, public health field staff, primary and urgent care clinics. Tier 3 will be specialty care clinics, laboratory staff, dental health clinics, and pharmacy staff that are not working at higher tiers. So that kind of completes my discussion on what the state and local level has planned for vaccine allocations, and I believe there will be some again for questions. So thank you.
Great. Thank you so much, Tiffany, for going over that. It was very clear and we really appreciate it. The final section that we're going to cover, so we've talked about the vaccines that are going to be available and their efficacy and safety. We talked about how the state and the county are thinking about distributing the vaccine. We're now going to get to a little bit more granular level, looking at how are we as a network across San Francisco Health Network, including ZSFG, how are we thinking about staff COVID-19 vaccinations within the first 2 weeks. So I'm going to first turn it over to Dr. Ellen Chen, who is going to start us off, and then I will finish off talking about our distribution and our workflow plan.
Thank you, Luke. So we wanted to convey the key themes for the approach that we're taking within the network in terms of COVID-19 vaccinations. The first is that any DPH or UCSF staff, both clinical non-clinical, will be offered a vaccine. It is not mandatory at this time, so it is an offer. Given the limited supplies, especially in that first part of the early stage that Tiffany showed of that curve of supply, staff will be offered vaccines at different time points over the next few months. And if staff work at multiple sites, this is mostly pertaining to those who work within the different hospital systems, we ask staff to select one site to receive their vaccination, so those 2 doses can be tracked. Students and trainees, with exception of the general, receive their vaccines at UCSF, so pertains mostly to the FCM residents. The second concept that we want to make sure everyone is aware of is that these vaccines that are coming to the general are allotted for the entire health network system, with the exception that Laguna Honda is not included. As Tiffany mentioned, the SNFs have a separate allocation system from the federal and state allocation system. And so we are focusing on the general hospital and also all of the sections of ambulatory care, which includes primary care, jail health, whole person integrated care, behavioral health services, and maternal, child, and adolescent care. So using the state and CDC guidelines, a multidisciplinary team has come together to develop risk groups for staff, which will be used to allocate vaccines. And the goal here is really to have an approach that is evidence-based, transparent, and equitable in offering the vaccines to staff and patients. So today we're really focusing on staff as our first phase 1A approach, and later to come, there will be many more conversations about patients, and indeed, how can we partner with the C3 as a health network to vaccinate the larger community of San Francisco, the most vulnerable communities. My comment here is that if we are wearing a lens of equity, it's really a key concept for all of us to communicate that the groups that we're talking about for vaccine prioritization are based on risk factors and not by how we value a staff member's work role. This is incredibly important as we consider all staff in the health network, both non-clinical and clinical, and because these roles are often stratified by economic and racial disparities. And so we wanted to be very clear around how we're defining risk of work roles. So there are 2 concepts here. One is the risk of exposure to COVID-19 in your work role at the site. And so you see here listed on the left side a variety of risk factors that can be considered in someone's role and the site that they work at. So, and then the other side of this is the risk of transmitting to others in terms of the site and the populations that someone works with. And ultimately, these risk factors were considered in an additive fashion, so that the more risk factors a role has, they were considered to be higher risk. I'll turn it over to Luke, who will go into details a bit about the group risk factors, groupings.
Great, thank you, Ellen. So I'm sure most of you probably now are wondering what are the various risk groupings that we are using across the San Francisco Health Network. And so I put these up here and I'll walk you through them a little bit. And so as Ellen said, our goal on this was to be evidence-based. So these were developed using guidance from the CDC as well as the California Department of Public Health. Additionally, we wanted to be equitable. And so we had a diverse committee, both here at ZSFG and at the network level, who came together to develop these 6 groupings. And then lastly, we want to be transparent about it. And so that's part of our goal today, is to start sharing this with all of you, so all of you are aware of this. The one thing I want to highlight about all these different risk groupings It is not meant to make a value judgment on people's work or where we sort of feel that they belong in the organization. These are just based on the guidance that we have from the best available information. As Ellen said, our goal is to offer the vaccine to everyone who wants it, but it may be at different time points over the next couple of weeks based on supply chain. So the way we thought about our risk groups here across the network and at ZSFG is really, one, what is an individual or staff member's contact with patients? Is it a sort of full-time direct contact all the way to no contact with patients? The second piece is what is their exposure to patients who may have COVID-19 or may have suspected or unconfirmed COVID-19? And so using that framework of patient contact and exposure to COVID-19, this is how we developed our 6 groupings here. And so just to sort of start at group A, these are frontline clinical staff who provide direct patient or client care in locations with high exposure to patients who may have either COVID-19 or suspected COVID-19. This, as you can see, actually goes all the way down to group F, where this is mostly staff who provide administrative support without routine or no patient contact. Now, some of you may be asking, which group do I fall in and when will I get my vaccine based on the groups? We're not sure at this particular time. A lot of this is based on the allocation of vaccine that we will receive. Based on some of the early numbers that we know that we have, we likely will be able to invite both groups A and B to participate in vaccinations. The other thing too I want to highlight is that within each group there are several operational areas. We will not be inviting all people within an operational area to get the vaccine at the same time. So as you heard from Vivek and Lisa, there are some side effects and we're still learning about this. What we don't want to do is vaccinate an entire operational area and then not be able to staff an operational area after the vaccinations. So we're doing it in a staggered approach. So if you're not initially invited and one of your colleagues is, that's the reason we're doing it, is we're staggering it just based on some of the adverse events we might or are expecting we might see. But we're anticipating that groups A and B will be invited in the first round. If the Moderna vaccine is actually going to be available the week of the 23rd, as we anticipate, we will start quickly moving through the rest of the groups. So we actually have a very high likelihood that we'll be able to vaccinate a large majority of our staff within the first couple of weeks. So what is the workflow going to be for next week and probably the week after? Again, I want to highlight, one, this is a very busy slide, so we'll be sending out the slides to all of you. 2, this is a moving target and a living, breathing document. This is our best guess of what we're going to be doing for the first 2 weeks. So bear with us, and this may change, especially as we get more doses of vaccine. So the workflow will be, the vaccine will become available, and the Pfizer one looks like that will be the first. We're waiting for the FDA EUA, which looks like it's coming soon. And then once the Western States Scientific Safety Review Workgroup approves it, we will then receive our shipments here at ZSFG. That is expected on Monday. If that all goes as planned, we will start sending emails out on late Monday or early Tuesday morning. It'll either go to your UCSF or DPH email, and that will be an invitation for you to receive the vaccine. And so there's a couple of branch points here that I want to sort of go through. The first is, as Ellen said, this is not mandatory. So you can decline the vaccine if you would like to, and we want you to decline it if you do, because if you decline it, we then can offer it to another person right afterwards. But just because you decline it in the first round does not mean you will never receive the vaccine. We actually will continue to invite you again in subsequent rounds, and this could be upwards of 2 to 3 weeks later. So just because you decline initially does not mean that you won't ever receive the vaccine. We will continue to invite you in subsequent weeks. If we don't hear an answer after 24 hours from the email, we're then going to work with your managers and leaders in each of the areas to do direct outreach, so we can either obtain that declination or schedule your appointment. What I want to do now is walk through if you decide to accept to receive the vaccine. So if you accept, you'll be asked a couple of questions and then be allowed to make an appointment at the Wellness Center. Appointments will be available Monday through Saturday from 8 to 4:30. And so again, this is Monday through Saturday for the first 2 weeks. It'll only be in the Wellness Center. We will not accept any walk-ins. When you show up to the Wellness Center, we ask, one, that you bring your ID with you, and then we will also be doing a verification that you have signed up and that you are in the right group to receive your vaccine for that day. At the end of receiving your vaccine, we will then make a second appointment for you, and then you will also receive a post-vaccine symptom handout. And more information will be coming out in the next couple of days about what to expect. But if you don't experience any symptoms, you can continue on with sort of your daily activities. If you do, you'll contact occupational health, and we will provide that number and also some guidance as well. So key things here, we're waiting for the vaccine to be approved. We're likely going to send out emails to the first two groups, A and B, starting either late Monday or Tuesday morning. So we ask people to check their emails and to respond promptly to it, even if you don't want the vaccine. We are likely going to start vaccinations probably next Wednesday if everything is approved over the course of the weekend and we receive the vaccines on Monday. So lastly, what are some key takeaways that we want you all to sort of walk away from? First, we're waiting for our final approvals. So we're waiting for the Pfizer vaccine, which is first in line. Next, we're expecting the vaccine, the Pfizer vaccine, to show up on Monday. We're expecting at least about under 2,000 vaccines that may be available. And again, this is for the entire network, including ZSFG. Initial invites will be sent out as early as Monday. So please check your DPH or UCSF emails and respond whether or not you would like to receive the vaccine. And again, just because you decline it doesn't mean that you'll never get it. And as I said before, we're following a staggered approach. So more than one group is going to be contacted, so that A and B and potentially even others. And various individuals within each group are going to be contacted in a very staggered approach to make sure that we don't decimate a workforce through the vaccinations. And if everything goes as planned, we're anticipating to start vaccinations next Wednesday on the 16th. So almost coming full circle on this pandemic, which I think is just incredibly exciting and incredibly optimistic for us. And with that, final thing, we're going to have a final word from our CEO, Susan Ehrlich, who unfortunately couldn't be here, but made a video for us. And so we'll play that.